Thank you, Ebes. Excellent. We are going to change gears again and move from the aortic valve to hypertrophic cardiomyopathy. Dr. Timothy Wong is our expert, our local expert in hypertrophic obstructive cardiomyopathy. He's going to give us a talk about the state of the art. Tim.
Thanks for inviting me, and I'd like to just start off by saying, does an HCM talk even belong at a valve conference? And hopefully over the next 9 minutes, we can have some nice discussions. So I'd like to posit that identifying a hypertrophic cardiomyopathy phenotype, the physiology of LVOT obstruction, may be relevant in certain instances in aortic and even mitral valve disease. Should obstruction occur either before or after such procedures, there's a variety of treatment options. And then finally, I'd like to touch briefly upon the state of the art in HOCM, which is novel myosin inhibitor therapy for the treatment of LVOT obstruction. So without further ado, this is a 70-year-old female with just very progressive dyspnea and exertion, and now resting dyspnea and CHF symptoms. And she's now so debilitated, she's wheelchair-bound. She happens to be on verapamil for hypertension, and an echo was performed in the long axis view. So what we can see here is that there's asymmetric septal hypertrophy. And if you look very closely in the outflow tract, you can even see a bright spot right on top of the mitral valve, which is suggestive of a callus from mitral septal SAM contact. So in this patient, you can also see that the aortic valve is somewhat calcified. There's some mobility to the leaflets, and then so, I think Doppler is really helpful here to try to tease out what's going on. And our colleagues at Hammett did this really fantastic echo where they show that at rest, there's not much obstruction going on. But with Valsalva, you can get both an LVOT and an aortic valve gradient. And then so the top right panel just shows the raw data, and I've taken the liberty of highlighting a late peaking LVOT gradient that's hidden within the aortic stenosis signal. And interestingly, this is only on provocation. So what would you do next? Would you just observe and then repeat the echo and hope things get better? You could add disopyramide as an anti-inotropic to relieve the outflow gradient. You could add mavacamten, or you could go interventional, alcohol septal ablation, and reassess for TAVR indications, septal myectomy plus SAVR. So we had a very nuanced discussion with this patient, and given her comorbidities, which I didn't list all of them, there's multiple other confounding factors, we decided to add disopyramide. She actually did fantastic. She felt great. She could do more at home. But then unfortunately her symptoms and the gradient returned. And we see that sometimes that disopyramide can wear off. She really wanted to avoid any sort of invasive intervention. We started mavacamten on her. I'll talk more about that later. That worked for a little bit, but again, her symptoms progressed. So then we did another echo to try to tease out, is this worsening LVOT obstruction or has the aortic stenosis gotten worse? And here in the bottom panel, you can see clear-cut, severe resting, early peaking aortic stenosis signal with a mean gradient in the 50 range. So definitely the aortic stenosis has come to the fore. But our knowledge that she had a pre-existing LVOT gradient caused by hypertrophied muscle kind of helped us influence our decision making. We knew we would probably have to address that as part of her overall management strategy. So she opted for alcohol septal ablation to treat the LVOT obstruction because she didn't want to take mavacamten lifelong. And then to sum up the case, Dr. Toma did a fantastic alcohol septal ablation. Just briefly, there's an overwire balloon in the first septal perforator there. We use echo guidance in the middle panel. You can actually see the echo probe on the fluoroscopy. And then on the right-hand panel, you can see a mixture of iodinated and microbubble contrast that was injected into the septal perforator as a test to mark out the site of ablation before the actual alcohol was proceeded. And then she'll now move on to TAVR evaluation. So why all this discussion about the LVOT? And it's basically focused on the potential for a rare but catastrophic complication of severe obstructive shock following the procedure. And there have been multiple case reports of morbidity and mortality in this situation. There are no guidelines regarding criteria for preemptive intervention, but there are definitely expert opinion articles, some of which has come out from UPMC, that at least discuss some of the variables involved. And I think it really boils down to the heart team concept that Ebes and Dustin have mentioned earlier. In the event of post-procedural obstructive physiology, IV fluids, phenylephrine as a pressor of choice, and then also very cautious use of anti-inotropic therapy can be considered. And also extremely cautious use of Impella has been described in cases like this. So I think bottom line, working as part of a robust heart team really can make a lot of difference. I'd like to change gears here and kind of go a little bit deeper into a novel drug that I mentioned earlier, which is mavacamten. So currently, for hypertrophic obstructive cardiomyopathy, first-line medical therapy consists of beta blockers and non-dihydropyridine calcium channel blockers like diltiazem and verapamil. Second-line therapy would be an antiarrhythmic, which has a potent anti-inotropic effect, disopyramide. And the guidelines mention this as part of an algorithm on the right here. But what if the patient fails these but is not really interested in mechanical intervention? Then a novel myosin inhibitor is now clinically approved on the market since April of last year. And the mechanism is unique in that it binds to myosin and changes its conformation so that there are fewer myosin heads available for the myosin-actin crosslinks that is necessary for typical sarcomere contractility. And in doing so, it performs as a negative inotrope. In a phase 3 Explorer trial demonstrated in about 250 patients that LVEF is relatively preserved, but the LVOT gradient can be markedly improved and symptoms improve with exposure to mavacamten. So based on that, it's clinically available. How we use it here is typically symptomatic patients, despite first or second line medical therapy, who either have a contraindication to mechanical septal reduction therapy or through just very in-depth patient-centered counseling elects to try this. And of note, because there's a small risk of systolic heart failure, prescribing this drug is through a mandatory risk mitigation program. So patients are counseled about the small risk of reversible systolic dysfunction. There's a mandatory echo imaging performed every 4 weeks for the first quarter and then every 12 weeks thereafter, and you have to follow a strict titration protocol. This is just one classic case of a young patient who failed first and second line therapy, was able to start mavacamten, and I'll just point out the middle row in the table here, where he started off with a gradient of 116, and now has a gradient in the 32 and 49 range, and is NYHA class 1 and completely asymptomatic. And he is now back to, he does line dancing and can actually go back to line dancing now. So I'd like to just recap what we've covered over the past few minutes, and that in rare cases, LVOT, HOCM physiology may occur either before or after aortic valve replacement. There's an evidence-free zone, but there's definitely a lot of anecdotal data and expert opinion regarding how to manage this, and I think working as part of our heart team is important for that. And then finally, there are now novel medications to treat muscular derived LVOT obstruction in the HOCM setting. And we're still getting more and more experience with this, and I think the future is bright for hypertrophic cardiomyopathy. I'd like to thank you for your attention and just thank all our clinical collaborators here, interventional cardiology, cardiac surgery, and like I said, it really takes a team approach to tackle this issue. Thanks a lot.